Ben, have you had a chance to look over this article? Hyperlipidemia as an etiological factor for Meibomian Gland Dysfunction. It's a comprehensive review, and honestly, it reinforces what many of us have suspected clinically for years.
I have Anya, and I agree. The sheer volume of epidemiological evidence they've compiled is compelling. The consistent finding that elevated serum lipid parameters, especially LDL cholesterol, are significantly associated with increased MGD severity across multiple studies really solidifies the link. It moves the conversation beyond mere correlation.
Exactly. But what I found most fascinating was the dive into the pathophysiological mechanisms. For me, the animal model data, particularly from the OPO-deficient mice, is the smoking gun. They show a direct mechanism. The severe hyperlipidemia leads to exaggerated lipid accumulation within the myocytes, disrupting the normal acinar architecture.
That lipid accumulation seems to be the central trigger for a cascade of cellular problems. The review highlights 3 key downstream effects: inflammatory dysregulation, oxidative stress, and the critical PPAR gamma dysfunction. The inflammatory response, with the upregulation of NF-kappa B and cytokines like IL-1 beta and TNF-alpha, suggests MGD in these patients is not just a plumbing problem, but a profound inflammatory disease driven by metabolic stress.
And the PPAR gamma angle is crucial for potential therapeutics. For our listeners who may not be familiar, PPAR gamma, peroxisome proliferator activated receptor gamma, is a nuclear receptor that essentially acts as a master regulator of lipid metabolism and myocyte differentiation. The article states that it's markedly downregulated in hyperlipidemic glands.
Which brings us to the most exciting part for clinical practice: the therapeutic implications. The fact that the experimental administration of the PPAR gamma agonist rosiglitazone partially reversed the Meibomian gland pathology in the hyperlipidemic mice is a huge signal. It suggests that pharmacologically modifying the systemic lipid and glucose environment could be a viable treatment strategy for MGD in this patient subgroup.
It certainly opens up a new frontier. We're currently treating MGD with warm compresses, expression, and topical anti-inflammatories. But this research suggests a systemic approach. Do we start thinking about statins or fibrates for MGD patients who are already borderline hyperlipidemic, even if their primary care physician hasn't initiated treatment?
That's a complex question, and the article acknowledges the need for prospective, longitudinal studies to establish true causality and optimal treatment protocols. But the clinical implication is immediate. We need to be more proactive in our screening recommendations. If a patient presents with refractory MGD, we should be asking about their lipid panel and potentially referring them back to their PCP for a metabolic workup. The article advocates for systematic evaluation of Meibomian gland function in all dyslipidemic patients, regardless of symptoms.
Agreed. The take-home message for me is a shift in our diagnostic paradigm. MGD is not solely a local ocular issue. It is frequently a sentinel sign of underlying systemic metabolic dysfunction. Recognizing this allows us to offer more holistic care and potentially prevent more serious systemic issues down the line.
Perfect summary, Anya. This review provides a robust framework for integrating systemic health into our dry eye management protocols. It's a necessary step toward personalized medicine in ocular surface disease.